So this discussion has brought up a couple of questions I'd like to flesh out that I think might be important for people viewing us. And the first is something that you said, Ruben. If a patient with high-risk MDS is started on a hypomethylating agent, and by 4 or 6 cycles, they haven't had what you would consider a response, is there a benefit in terms of survival in continuing that therapy? Do we have any data to inform us on that? Or should we not continue?
It's a bit, I don't know if we have a lot of data. Like, I think in landmark analysis from the AZA001 study, there was suggestion that patients that had stable disease did better on azacitidine compared to the conventional arm regimen, up probably to 9 cycles, and then after that it was lost. And it's somewhere between 6 to 9 cycles, I think, you drive the maximum benefit at a stable disease. But it's not much data, it's subset analysis, it's a landmark analysis in one study, and I think the reality sometimes we continue because of lack of better options or absence of other options, basically.
And I would say that in practice, I think we very much follow that sort of model. I think with truly a less than one handful of approved options, you know, alternatively to clinical trials, we really look for evidence of progression, you know, as the main driver of an alternative therapy. Either progression or true issues with tolerance. But the patient who is both tolerating the therapy and having stability probably is having benefit. It's difficult to prove stability, but probably is having benefit.
You know, I want to add, in the lack of alternative available, somebody with stable disease, I think in our practice today, should remain on a treatment. In fact, if they progress, and I mean progression, for example, blast going from 10% to 30%, their outcome is very poor, with the median survival is only 4 months. While patients who are stable, in a good shape, tolerating, they still do benefit. Not as much as somebody who's in complete remission doing so great, still better than if progressing on therapy.
I agree with you, Ali, I think, but one thing is also in the United States, we use azacitidine for both what we call lower risk and higher risk. So in the higher risk, I think I totally agree with you. In the lower risk, sometimes I think it depends on what we are setting our goals. If we are going for transfusion independency or like reduction of transfusions, after a certain number of cycles, if we are not seeing that, unless you are worried about some inherent risk disease feature that this is a higher risk patient from the get-going, I think one could make a case that if you did not see the goal of therapy after a certain number of treatments, to stop the treatment.
But that brings us to set a goal. Because the criteria of response, where they apply very well to high risk, they may not apply for somebody with a low risk. And asking for a complete remission in low risk may not be very realistic. So improving the cytopenias will improve the outcome of these patients.
So to summarize what I've heard from the panel then, is if you have a patient with high-risk disease where your goal is to extend survival, in the absence of any definite data, and in that patient, in the absence of toxicity or progression, we would continue those patients on their current therapy, azacitidine or decitabine. I'm going to come back to the question of what do you do in a patient who has been responding and then loses a response. I'd like to come back to that because I have one other